A different level of care due to their risk level are managed in separate facilities from members of the general public. I would like to now move on to the clinical update as of 4 p.m. on Sunday, 8th of November 2020. As of this date, we tested 34,012 patients, with a total number of positive cases amounting to 5,849. Over the last 24 hours, we have recognized 11 positive cases. At this point in time, we have 606 positive cases, and this is broken down, total active positive cases, and this is broken down into 37 patients in hospital. At this point in time, we have patients at the Couva Medical and Multi-Training Facility, approximately 24 patients, of which 21 are ward-level patients and 3 are in ICU, 12 patients at the Cora Hospital, and 1 patient at the Scarborough Regional Hospital at the Fort. At step-down facilities where we have COVID-positive patients who are generally of a lower risk but are unable to self-isolate at home, we have a grand total of 32 patients. These patients are broken up or divided between the Daybay Academy, which has 18 patients, the Claxton Bay Correctional Facility, which has 14 patients, and at present, the Tobago Step-Down Facility has 0 patients. In terms of state quarantine facilities, which covers patients who are returning nationals and expatriate personnel for the essential services sector, we have 302 persons in state quarantine. This is across 9 facilities, which include hotels and state facilities. It is important to note that on Saturday night, we had a very successful repatriation exercise in which 79 persons from New York City were repatriated to Trinidad and Tobago. We have an additional 2 repatriation exercises scheduled for Thursday, 12th of November, where persons from Miami will be repatriated, and an additional repatriation exercise on Friday, the 13th of November, for persons who are in Barbados. Thus far, we have had no deaths over the weekend, so the deaths remain constant at 111 persons. We, of course, extend condolences and sympathy to the family members of the deceased. In terms of the overall occupancy of the parallel healthcare system, it is currently at 26%. Over the past 2 weeks, we have noticed that this has been a fairly constant figure, and if there have been marginal increases, for example, a 2 to 3%, it has rarely been because of the filling of the quarantine facilities in which we have returning nationals. In terms of our ambulatory bed capacity, it is currently at 14%, and we have 4 of 7 hospitalized that are currently operationalized. That is the Arima General Hospital, the Augustus Long Hospital, the Cora Hospital, and the Couva Medical and Multi-Training Facility. The critical factor that we look at in the parallel healthcare system for the management of very ill, severe, and critical patients would be the number of ICU, intensive care unit, and high dependency unit beds in our parallel system. As of yesterday, the 8th of November, there were 4 patients out of a total of 38 ICU beds within our parallel healthcare system. This was broken down as follows. There are 2 patients at the Cora Medical and Multi-Training Facility, 1 patient at the Augustus Long Hospital, and 1 patient at the Arima General Hospital. This gives an overall occupancy of 11%, and at present we have 34 ICU beds available. As I had indicated on an earlier press conference, at present we have 91 ventilators for use in the parallel healthcare system that can be operationalized according to need. The high dependency unit occupancy over the last 2 weeks has been fairly low. In fact, over the past 4 days, we have had between 0 and 1 person hospitalized in the high dependency unit. At present, the percentage occupancy for the high dependency unit is 2%. Regardless of the status of the parallel healthcare system and the relatively low occupancy rates that we have indicated at previous media conferences, we are urging the population to continue using measures that will reduce the risk of the COVID-19 virus. We would like to remind members of the population that they should use the proper wearing of masks, and additionally, if they are in close contact with persons, social distancing measures should be exercised. Hand washing and sanitization are also essential in decreasing the spread of the COVID-19 virus. And of course, if you are ill and you have any viral symptoms, please ensure that you stay at home and contact your employer. Again, you can reach the Ministry of Health at 877-WELL for further information on testing or on symptoms of the COVID-19 virus. Lastly, I would like to remind members of the population on the flu vaccination drive that is currently in progress by the Ministry of Health. We have approximately 100,000 vaccines in storage that have been ordered, with an additional 100,000 being ordered in January. The flu vaccine is essential for reducing the risk of influenza, especially in high-risk populations such as the elderly, pregnant females, children, and persons with diabetes, hypertension, lung diseases, and cancers. I would also like to urge members of the population to vaccinate even though they may not be considered high risk, simply because they may be in contact with relatives or co-workers that are considered high risk. At present, we have noticed a decline in the uptake of vaccines. As of week 4, we have the administration of just under 7,000 vaccines, that is 6,963. At week 5, this number dropped to 5,329, and in week 6, 4,716. This gives a cumulative vaccine uptake of 32,667, which is about 20% less than our target of 40,000. In this regard, I would like to urge members of the population, as well as employers, members of chambers and civil society organization groups, to remind their members and the population of the importance of the influenza vaccine. In closing, I would like to remind persons that an additional media release with updated figures as of Monday the 9th of November 2020 will be available at 4 p.m. from the Ministry of Health on social media and with various media houses. Thank you very much. I now pass you on to Ms. Alcantara and Dr. Hines.
Thank you very much, Dr. Richards, especially for that reminder to get the flu vaccine. Ladies and gentlemen, it's free and available at health centers. Please call for details. And next, I hand you over to Dr. Hines and Mr. Siram Singh, who will update us on some COVID-19 epidemiological information. And they will also discuss the manipulation of data into graphical formats. We go now to Dr. Hines and then Mr. Siram Singh.
Thank you, Ms. Alcantara. Good morning to my colleague, Dr. Richards, and my colleague, Mr. Siram Singh. Today, we're going to go through the epidemiologic update, and we begin with the usual slides showing the time trends, the demographics, and we'll go into additional detail on the geographic information. So, move to the next slide, in fact, the next two. The time trend that we've been observing next is the epi curve that we have continually updated. And this curve Next, thank you. This curve shows that we have continued on that slow downward trend throughout the months of September, October into November. September being the blue, October being the green, and November being the orange that you're seeing at the very end of the graph. Our rolling average number of cases has continued to decline slowly. We are currently seeing an average of around 21 cases per day averaged over the previous 7 days, and we are hoping that we see a continued decrease, in spite of the fact that we have noted we have increased the amount of movement that individuals have been engaging in over the previous 2-week period. Next slide. Looking at the demographic distribution, next please, we see that the age and sex distributions of the cases remains fairly consistent. The majority of cases being in that 25 to 49 age group. That's 54.7% of all the cases. Under 25s being 17%, and 60 plus being 13.8, nearly 14%, with men outnumbering women slightly and accounting for 52.9, nearly 53% of the total cases. If we move to the next slide, we see that the age-sex distribution for the COVID-19 fatalities is slightly different. The males taking up 75% of the total number of deaths, the deaths in the over 60 age group occupying the majority, but we are again emphasizing that we do have deaths in the younger age groups, including the age groups below 25, and we want to continue to encourage all individuals to make every effort to reduce their risk of contracting COVID-19 by adhering to all of the guidelines that we have been repeating and promoting over the past several months. If we move to the next slide, we see the cumulative, meaning from the start all the way up to date, the cumulative cases as they are spread across the country, sticking to the population centers and to the populated roads, even in rural areas. And we will see a little more about how we actually utilize this information at this stage in the epidemic to go after the areas where there are new cases and to help to boost the public health response. So that geographic information activity, I will hand you over to Mr. Siram Singh, who will provide some additional detail on how we utilize our geographic information systems to aid in our response to the new cases as they arise at this point in time. Mr. Siram Singh.
Thank you. Dr. Miriam Abdul-Richards, Dr. Avery Hines, Ms. Candice Alcantara, members of the media, and our listening and viewing audience, good morning. This morning we continue our look at the use of GIS technology within the Ministry of Health as we work towards achieving our objective, that is to move from community spread to cluster spread. Today we'll present a variety of maps and analyses which will really represent some of the work which we've been doing thus far. But I'll point out up front that while we present maps, there's quite a lot of spatial analysis in general, which takes place before we could get to the point of presenting a map. These analyses provide us with actionable data which we share with our relevant stakeholders, key among them being the CMOHs, to facilitate further investigation and intervention as required. So as we move to our first slide, we look at our county maps. In this case, we are looking specifically at County Victoria. You'll recall last week we mentioned 3 counties which had recorded the highest number of new cases, one of which was County Victoria, the others being County St. George Central and County Caroni. The map on the left provides us with Phase 2 not repatriated COVID-19 cases for the period October 17th to October 30th, while the map on the right provides us with Phase 2 not repatriated COVID-19 cases for the period October 24th to November 6th. When looking at the map, it's clear that while there continues to be cases across various parts of the county, we are seeing that there are less counties recording new cases. However, while there are less communities recording new cases, there are 2 communities which recorded cases during the period of October 24th to November 6th. which did not record cases during the period October 17th to 30th. What is important is to appreciate that these maps are accompanied by the relevant information about the patients, actionable information, which we provide to the CMOHs, the County Medical Officers of Health, so that further investigations can be done to determine if there are emerging clusters and what may actually be taking place within these communities. Over time, as we look at these maps, which we generate on a weekly basis, we really appreciate what is taking place in the county as time progresses as it relates to COVID-19. Now, if we move to our second map, I want to point out that this is information that was created for demonstration purposes only. It's artificial information. It does not represent accurate location or attributes of any COVID-19 cases. Again, I will repeat, it is data for demonstration only. Now, what we have been able to do with the software and the GIS technology is to identify clusters as they occur, emerging clusters. Having identified these clusters, we again extract actionable information. The information attributed to each of the cases which fall within each cluster is extracted, and as we move to the next slide, we'll see that this information identifies not only the cluster, but they identify the patient information. Again, you will see as we move to the next slide that it's strictly artificial data created for demonstration purposes. We can extract information for each cluster, send it to the relevant County Medical Officer of Health so that they could action accordingly. Whether they need to do further investigations to determine what is taking place in that area, or whether they need to begin intervention methods. So this is just one of the ways in which we've been looking at it. Now, looking at this data, again, we use this as we work towards achieving the ministry's objective, that is moving from community spread to cluster spread. This, however, is looking at the data spatially, so just in terms of space and location. As we move on to the other slide, we will see some of the space-time analyses that we have been doing within the ministry as we again work towards achieving our objectives. I'll point out that this type of analysis allows us to understand not just where the clusters are occurring, but when they are occurring as well. I will point out in this map as well that each cylinder may be of a different size, because the cluster will be of different size, different locations, etc. But they are also of different heights. The height of each cylinder or cluster, in this case, represents the time frame, the length of time in which that cluster would have occurred. Understanding where it occurs is important, yes, but also understanding when it occurs is also important. Using this type of information, we could determine what has taken place and use this going forward, again, to inform the CMOHs so that the relevant further investigations or intervention methods can be adopted. Thank you very much.
Thank you very much, Mr. Siram Singh, for explaining how we move from data and take this information and put it into a format that we can use to make decisions, decide where we focus our energies so that we can help to manage COVID-19. We go now into the question and answer segment. Members of the media, we ask you please indicate your name, the media house that you represent, and we ask for, of course, 2 brief and to the point questions. We begin with CNC3, please.
Hi, morning everyone. Rashad Khan, Guardian Media Limited. Okay, so my first question, Dr. Richards. Active cases continue to go down relatively, but we are bringing on these new facilities. So is this anything to do with the inmates at the maximum security prison testing positive and even to possibly be bringing home more nationals? And second question is to Dr. Hines. That strategic objective that the ministry has had since we entered the community spread to return back to cluster cases, how far are we from achieving that goal?
Dr. Richards?
Thank you, Rashad, for that very topical question, especially given the Minister of National Security's announcement that we would be doing more repatriations in the coming months. So your first question was about the increase in the number of facilities or state facilities in the parallel healthcare system. So we are going from 21 facilities and increasing that number to 23 facilities by the end of this week. And the need for additional facilities is centered around the risk levels of persons who are either suspected or confirmed COVID-19 cases. For example, one of the additional facilities will be a correctional facility in Tobago for prisoners. As you would imagine, prisoners cannot be really kept in self-isolation at the current maximum security prisons such as the remand yard. Such a case can result in a very rapid spread of the COVID-19 virus within the prisons, which is a risk to the prisoners themselves as well as the staff attached to the maximum security prisons. So when I speak about a risk assessment for persons who are coming in with COVID-19, I'm really speaking about looking at, firstly, the country of origin or where they are coming from. And that would really apply to repatriated nationals. We also consider the risk level of the person. So, for example, if someone has comorbidities or, as we say, other pre-existing medical conditions such as diabetes, hypertension, other lung disorders, or any other immune compromised disorders such as cancers, we would put them in a separate facility as opposed to one where persons are of a lower risk. So, for example, we would put someone with comorbidities in a facility such as the Quora Hospital or the Couva Medical and Multi-Training Facility for observation. Another factor that we look at in the placement of persons in facilities would be the socioeconomic conditions that a COVID-positive individual are subject to. So we have allowed self-isolation and home quarantine for persons who are either primary contacts or are confirmed COVID-19 positive patients. If a patient, however, is living in an environment where they are unable to really self-isolate truly in terms of their living arrangements, we recommend and we advise that that person is self-isolated in a step-down facility such as the Day Bay Academy. Additionally, if a person has any sort of or primary contact has a similar challenge, we would of course recommend that they are isolated in one of our suspect hospitals based on their risk level. Other factors that we consider in the selection of the parallel healthcare facility would be if they are patients, for example, from an elderly home, if the patients are of a psychiatric nature, of course, which would require a different level of concomitant management in addition to COVID-19. Additionally, we look at persons such as deportees who require an additional level of security as opposed to members of the population. And of course, I discussed the prisoners. Now, another factor that we are considering in terms of the number of facilities would be the increase in the number of repatriated nationals that we expect in the next 2 months. At present, we are currently using 7 of our 9 state facilities for repatriated nationals. We have been doing a significantly increased number of repatriated nationals within a 7 to 10 day period. In fact, the last grouping of repatriated nationals accounted for 244 persons within a 7-day period, with persons coming from Miami, New York City, and from Barbados. We have included an additional facility, the Cape Ock Hotel, which will add 90 beds for persons who are desirous of returning to Trinidad and being quarantined for the 7-day period. Additionally, we have other facilities for the quarantine of returning nationals. For example, the Cascadia Hotel, the Paria Suites Hotel, the Chancellor Hotel, the Regent Star Hotel, and additionally, the Homer Football, the Day Bay Halls, the Freedom Hall at UWI, and the Canada Hall at UWI. At this point in time, repatriated nationals account for the greatest percentage of persons in the parallel healthcare system. And with this in mind, we have been able to exercise the interoperability function of the system by basically converting the Freedom Hall and Canada Hall facilities into quarantine facilities as opposed to step-down facilities. Lastly, the selection of centers would also be dependent on, for repatriated nationals, on the country of origin and the physical layout of a center. So, for example, persons from the United States and from Canada would be considered high risk as opposed to persons who are coming from other Caribbean islands where there is cluster transmission as opposed to community transmission. We do not mix persons from different countries, and so based, as I said, on the physical layout of the facility, we would tend to have one country in one facility or one building. Additionally, we look at the time and turnaround factors that are required in facilities. We had initially put it at 10 days, but at present we have been able to do rotations and additional intakes of persons actually within a 9-day period, which allows us for an increased number of repatriates. So, in conclusion, Richard, there are several factors that account for the selection of a site in the parallel healthcare system, such as the risk level and assessment of the patients, the time span, the country of origin, the pre-existing or presence of pre-existing medical conditions, socioeconomic factors, as well as if they fall within a vulnerable population, that is prisoners, deportees, the elderly, and persons who have psychiatric illness and require hospitalization. Also, we must always consider the logistics that are involved in terms of the readiness of the facility, the availability of human resources, and testing capacity at the time. So I hope that this comprehensive summary answers your question. I now pass on to Dr. Hines.
Okay, thank you, Dr. Richards, and thank you, Mr. Khan, for the question. Now, assessing how far we are from the objective of returning from community to cluster spread is a relatively complex sort of undertaking. The first thing that we would look at would be the proportion of the cases that we are seeing that are coming from clusters as opposed to arising what we would call de novo without any known exposure in the community. But the examination, the exploration of the data doesn't stop there. Once we have reached to a point where we see that the cases coming from clusters outweigh the ones coming from communities significantly, we also look at the cases or look for cases that we may not be seeing, look to see what sort of activity we are seeing with flu-like illness showing up at the health facilities where, for example, people may not have been swabbed or may not have agreed to have a swab done. We look at the flu-like activity when we do case investigation around a cluster of cases. We look at a number of factors that indicate, with a little more completeness, the background respiratory illness activity within the community. So it won't be just a case of saying, well, we've gotten to a certain proportion of cluster versus community samples and therefore we are back at cluster. There's a lot of background investigation that we will continue to do to be sure that we aren't missing cases that may be turning up in the periphery, so to speak. So while we do see that we're trending towards more of the cases being cluster related than de novo community cases at this point in time, it would be a little premature to say how far we are from the actual cluster only phase until we have a little more of that background information, which we're currently both pursuing and processing.
Thank you very much, Dr. Hines, for reminding us we've come a long way, but we still have a long way to go. So please continue to follow the new normal guidelines, especially wearing your mask, staying at home if you are ill, and staying away from persons outside of your household. And we go now to AZP News, please.
Hi, good morning, everyone. I'm Harry, azbnews.com. My first question is to Dr. Richards. As we move to have more private facilities helping with quarantine, can you give us an idea of how these facilities are procured? In other words, is it the ministry you chooses them, or do they apply? Is it sole select tender? Can you give me an idea about that? And my second question to Dr. Hines: there are reports this morning that Pfizer and BioNTech, they have developed a vaccine that seems to be effective in 90% of the patients it was tried on. Can you give us an idea what does that mean for us in Trinidad and Tobago, and has the Ministry of Health taken note of this? Thank you.
Thank you very much, Prior, for that question that really asked me to discuss the procurement and exactly how the private facilities were selected. So in the first instance, the Ministry of Health requested expressions of interest for persons and hoteliers who were interested in providing a service for quarantine facilities. That was done through the Hoteliers Association in a very transparent manner, and a list of requirements for the hotels based on the occupancy levels, the provision of services, infection prevention and control practices was circulated to all members. We gave them a certain deadline, and we requested proposals from them, which were then assessed by the Ministry of Health. The assessment from the Ministry of Health was actually done by a multidisciplinary team and really looked at 9 factors within a framework which was standardized. That allowed for a standardized rating for each hotels, which would have been very fair. That is, we compared apples with apples. So the 9 criteria that we used at the Ministry of Health would have been, firstly, the clinical setup of the facility. That is, if the facility was able to house an area that could be isolated for the clinical management of patients. Even though the facilities are private run, it is important to note that the Ministry of Health physicians provide assessments, swabbing, and coverage inside the facility. The next factor we looked at was the infection prevention and control practices and the ability of the private facility to be separated into what we call hot and cold zones to minimize the risk of the infections. We also looked at the public health component of the facility to ensure that all regulatory aspects with respect to, for example, food handlers licensing, drainage system, wastewater disposal, waste disposal were intact and up to date. We looked at the engineering component of the hospital in terms of the state supervised facility. For example, if the air conditioning system, if there was a boiler system, the water treatment systems, fire alarms were in order. There was also a review of the disaster preparedness plan as well as the occupational safety and health plan for the hotel by our team. We also looked at the legal aspects to ensure that the hotel itself was contractually had the appropriate contractual obligations and was willing to enter into agreement with the Ministry of Health. Of course, as in any agreement and any procurement, cost effectiveness was considered, and in terms of the financial agreements for these hotels, we negotiated a special rate for returning nationals given the economies of scale principle in that there were a larger number of persons at the hotels. Lastly, we also considered the socioeconomic conditions around the hotel. So, for example, we considered if the hotel was in a high-density residential area or if there was some sort of agreement from the residents within that neighborhood, as we did not want to have any sort of problems within the neighborhood. I neglected to mention another factor that is very important, and that is the security concerns around the hotel. We had to ensure through the Trinidad and Tobago Defense Force that there was appropriate perimeter security at each of these hotels that we have been using. So, in summary, the Ministry of Health used a very transparent procurement process to identify hotels that were interested in becoming state-supervised facilities, and we ourselves conducted a multidisciplinary inspection for the use of the hotels. Lastly, we have also looked at quality assurance and quality control mechanisms within these hotels to ensure that all guidelines and policies provided by the Ministry of Health are in place to ensure the safety of our repatriated nationals and our expatriates attached to the oil and gas sector. I now pass you over to Dr. Hines for his discourse on the vaccine.
Okay, thank you, Dr. Richards, and thank you, Prior, for the question. Now, I know it's a very exciting time in the vaccine world and in the scientific world, having at least an initial report of a vaccine showing some measure of success, but it's important to emphasize that it is still, as we say, early days yet. This is an experimental type of vaccination. It's one that uses the introduction of genetic material, RNA in this case, as opposed to the protein coat, which is usually what they would use to train the immune system on how to recognize future experiences or encounters with a pathogen, with a virus in this case. So that in and of itself is part of the reason that we're not sure exactly how this will go, but the short-term results that they've seen so far have shown what they said is a 90% protective effect. We have to bear in mind, however, that the number of persons who would have developed COVID and the cohort that they would have been compared with is still relatively small, and that as additional data comes out of that study, the actual percentage protection may change. So the 90% is a nice benchmark at this point in time, but as additional data rolls in, that level of protection may in and of itself change in one direction or another. Another thing to remember is that besides being a very small group of individuals, it's over a reasonably short space of time. They have actually indicated that an additional 2 weeks would be needed to have enough information to take to the vaccine regulators with regard to whether to proceed further in licensing or allowing the further use of this particular vaccine. Then there's the issues around the actual storage. The storage conditions for this particular vaccine require negative 80 degrees Celsius, as opposed to the vaccines that we would normally have in a vaccine fridge at -2 to -8, or 2 to 8, or whichever it depends on the vaccine. But different vaccines have different ranges of temperature within which they remain viable, and this is actually much lower. So the ability to store vaccines with that requirement is another issue. And of course, beside the long-term safety, which is something that we will only be able to have a better answer to with the passage of time, the long-term efficacy, the long-term effectiveness, the long-term how long the actual protection lasts is still unknown. So while we're quite excited, we join the world with the excitement about having a bright spot in the scientific literature. We are still maintaining the level of caution and scientific rigor that would be required to review the results further before deciding what this particular outcome means for Trinidad and Tobago.
Thank you, Dr. Hines, for that reality check. And we go now to Express newspaper, please. Are we ready with Express? I think we have Ms.
Kim Bojram from the Express. I'm going to ask the doctors to repeat themselves a little bit by revisiting the repatriation issue. And so looking at some of the announcements, which would have offered hope to some people, but in reality what it means for thousands of people still outside is that they're not going to make it home anytime soon for Christmas, the foreseeable future, and will be facing their first winters abroad. Can we revisit the issue, or what became of the issue of allowing some people to quarantine at home, to come back in and self-quarantine, some professionals? There were a couple of options bandied about months ago, but I think that seems to have been shelved. So what is that option in terms of quarantining at home for repatriates? Is that off the table for now? And also going to the restrictions at home, some of which have been lifted. Restaurants are now back at dining at 50%, but no alcohol. And so we know the argument that the bars are putting forth. But people, the general public is going ahead and consuming, it seems, more alcohol in their communities. At home, people are still outlining having the alcohol. So can the doctors give us their take on no alcohol in restaurants? And I mean, is that a sort of moral policing or is it really that people will consume alcohol and lose their senses and begin spreading the COVID in the restaurant? Thank you.
So thank you very much for that question. As regards the subject or topic of repatriation, I would just like to remind members of the population that the approval for entry into Trinidad and Tobago for a repatriated national or an expatriate falls under the purview of the Ministry of National Security. The Ministry of Health is responsible for the assignment of quarantine spaces based on the risk level and availability of nationals and expatriate personnel. In terms of the issue of allowing persons home and allowing home quarantine, that is guided by the Ministry of Health's policy on returning nationals. And we actually have two policies, one for returning nationals from high-risk countries and one for returning nationals from low-risk countries. High-risk countries are, we assign them or we identify them on a weekly basis via the WHO's situational epidemiological report. And basically those are countries in which community transmission or cluster transmission has been identified. I have to note that the vast majority of countries that our nationals are returning from, such as the USA, UK, Canada, Barbados, continue to be considered high risk because of the description being community and cluster transmission. For persons coming from low-risk countries, the WHO identifies the transmission spread as either being no cases or sporadic cases. Thus far, we've only been able to quarantine approximately 5 persons at home from Grenada, because Grenada is the only country that we have looked at or we've received exemptions, requests for exemptions to enter into Trinidad and Tobago with country with low spread in terms of no cases or sporadic cases. As regards the decision for restricting alcohol at restaurants and the closure of bars, this is a policy decision that was taken by a group of persons based on the science and evidence of the impact of alcohol. And in summary, we believe that alcohol from a behavioral pattern causes a disinhibition of behavior and thus results in persons reducing the risk or reducing their anti-COVID measures in terms of face mask wearing and proximity, thus increasing their risk of COVID-19 transmission. Thank you very much.
Thank you, Dr. Richards. We go now to Newsday, please.
Hi, good day. Ryan Hamilton Davis, Trinidad Newsday. Just two follow-up questions for Dr. Richards. The Minister of Trade last week forwarded a report on the Arima Racing Club and their reopening strategy. Has there been any update on what reaction or what response there is from that? And secondly, there was a person who unfortunately passed away on one of the repatriation flights. We were told that there was supposed to be an autopsy report done on that, and we'll be getting the results on that soon. I was wondering if you could tell me what those results were. Thank you.
Okay, thank you very much. The two questions that you have asked really demonstrate the intermittent.
Just Dr. Bright.
Yes. Thank you very much for your questions. The two questions that you have asked really demonstrate the interministerial collaboration in terms of the national response to the COVID-19 pandemic. As regards the reopening of the Arima Race Club, that guidelines or strategies would really have to be reviewed by the legal department of the Ministry of Health and then the clinicians at the Ministry of Health to ensure compliance with the public health regulations as well as COVID-19 mitigation factors. That is, factors to reduce the spread of COVID. With regards to the repatriation flight from New York City, in which unfortunately an elderly male passed away, the Ministry of Health awaits the autopsy report, which is channeled through the Ministry of Foreign and CARICOM Affairs to us. As of this morning, I have not seen that report, but we can share any sort of information given patient confidentiality rules in an upcoming media conference. Thank you.
Thank you very much. And we go now to TV6, please. Do we have TV6? Mr. Lakshman Singh? I think that you should be moved. Okay, I will move from TV6 to CL Communications, and we'll come back to Mr. Lakshman Singh, please. So let's go to CL Communications.
Good morning, everybody. Natalie Singh, CL Communications. I just wanted to find out, is there a policy for the deaths on repatriation flights? Is there specific rules with regards to how a person or should be treated? And then secondly, are you confident that if there is a surge of cases, there are enough bed spaces in our country now? Thank you.
Okay, Ms. Singh, I'll take that. I'll take that question on the parallel healthcare system and the repatriation efforts. So firstly, any policy on the death of a person, whether they are on in terms of a repatriation flight or if a death occurs abroad, will have to be managed by several ministries. Firstly, any request to have that repatriation of human remains would need to come through the Ministry of Foreign and CARICOM Affairs prior to approval by the Chief Medical Officer. So the policy would really be centered initially by a request that is channeled by relatives and the funeral home in the country or place where the death was, where the death occurred. Of course, at this present time, we would look at the autopsy to ensure that it was not a COVID-19 related death before we make a decision. With regards to a potential surge in cases that we have to consider, given an increase in repatriations and given the relaxation of restrictions, we are confident that our current capacity of 1,551 beds that will increase to 1,651 beds is sufficient given the number of persons who usually require hospitalization. If you recall, the WHO figures in terms of the severity of patients indicate that 80% of persons are asymptomatic or have very mild symptoms and so can be self-isolated at home or in a step-down facility. 15% require high dependency unit care and 5% require ICU care. At this point in time, we have 57 high dependency unit beds, as well as other beds in hospitals such as the Cora Hospital, the Augustus Long Hospital, that can be converted to high dependency unit beds. We also have 38 ICU beds present in our system at present, and we can upscale that number to 91 beds based on our ventilators and staffing capacity. There is also a feature of interoperability to convert the quarantine centers, such as the Canada Hall, Freedom Hall, the Debe Halls facility, and the Home of Football that can be really switched across or converted to step-down facilities for positive patients who are either have mild symptoms or are well. So in summary, I believe that the parallel healthcare system is resilient enough to manage an increased number of cases. Thank you.
Thank you very much, Dr. Richards. And we have a follow-up question from CNC3, please.
All right, good morning again. So, Dr. Richards, is it possible for you to give us a breakdown of the bed spaces in each of those two facilities that you mentioned, and how much additional would this, or how much is this going to cost taxpayers?
Which two facilities are you referring to, Rashad?
The two new ones that are going to come on board by Friday.
Okay, so one of the facilities is the Cape Park Hotel. The Cape Park Hotel would have a bed capacity of about 90 beds. That should not cost taxpayers any significant funding because the cost is basically by direct payment. That is, repatriated nationals will be offered the option of staying at the Cape Park Hotel, but would be responsible for all costs that are incurred. The second facility would be the Tobago Correctional facility, which adds an additional 10 beds. At this point in time, I would have to receive confirmation from the Ministry of National Security because this is a co-shared facility between the Ministry of Health and National Security as regards to the direct costs of running this facility and the indirect costs in terms of the Ministry of Health staffing and so on. So we can look at that from Ministry of National Security and Health Facility and provide you that information at a later date. Thank you.
Thank you, Dr. Richards. And do I see a follow-up question from Express Newspapers? Ms. Budram? Just waiting here to see if Ms. Budram has a follow-up question.
No. Morning again. Thanks again. Yeah, I do. There was a really unfortunate case of a gentleman having passed on a Caribbean Airlines flight 2 weeks ago. So just asking if there's any follow-up in terms of the reports that would have gotten to the Ministry of Health, anything different that may have been conveyed to the public within the realm of respect for the family. Condolences again to that family, and unfortunately must ask the whereabouts of the gentleman's body and whether or not the Ministry of Health knows if that gentleman has been able to return home for his last. Thank you.
Thank you very much, Ms. Budram, for that question. We did address a similar question in this morning's conference, and the response was provided. So thank you very much. I think we have come to the end of this morning's media conference. Remember that any gain that we have seen in this fight to manage COVID-19 has come about because of our collective efforts to follow the new normal guidelines. We know it is challenging, but we must stay the course. Continue to do your part to protect yourselves and your loved ones. Please only come out of your homes for important things like going to work, to the grocery, getting your flu vaccine, having your children immunized. Those are all important things that we want you to leave your house to do. And of course, everyone, please wear your mask.